Hey, welcome everyone. Thank you so much for joining us today at our Human Factors Forum. I have the pleasure of introducing our speaker today, Dr. Adeola Bamgboje-Ayodele, who is a lecturer from the Design and Innovation Centre at the University of Sydney School of Architecture, Design and Planning. Prior to this, she was a research fellow in human factors within the Faculty of Medicine and Health at the University of Sydney, where he led a research stream that looked at consumer-facing digital health tools and virtual care technologies. The research to date is focused on digital health intervention design, development, evaluation, and implementation to benefit clinicians, patients, carers, as well as healthcare organizations.
Thank you so much for having me. Evie has done a great job. Today we'll be talking about two large programs of work around designing safer virtual care, looking at virtual hospitals and aged care home settings as well. The first stuff, I will give a bit of an outline of the talk. Hopefully I can get through in time. I'll tell you a little bit about me, the Australian context, and then the two large programs of work and my take-home message. So this is me. People find it funny. Everyone usually asks me, are you a nurse? What do you do? And people find it surprising when I say, no, I actually don't have a clinical background. I have a Bachelor of Computer Science. And then in my master's degree, I moved more into information technology. And during my PhD, that was when I started doing digital health. And then I completed 2 postdocs position working on the design and evaluation of digital health technologies, more specifically virtual care in the last 5 years or so. Before I moved into a tenured role. And all those pictures scattered around are just around some of the tools that have helped in the design or evaluation or implementation over the past few years. Okay, so I want to talk a little bit about the context first, just so you understand the background for the studies I'll be talking about. Anyone ever been to Australia before? No? One? Only one person. And online, how many people? Two people. Oh, okay. That's good. All right. So I come from a place on the east, so New South Wales there. That's Australia. And our Australian healthcare system is a mix of both public and private service providers. It's funded by all levels of government, insurers, NGOs, and the likes. But the way our healthcare system is organized is also the way our digital health is organized, in that they are almost in silos. And I'll explain that in a bit. So we've got our Commonwealth, our federal government initiatives, our state systems, and then you've got your consumer tools and gadgets, and they all don't necessarily talk to each other. I don't know if that's the case here as well, but that just tells you a little bit about the current situation when we look at the interoperability of our systems in Australia. So we've got a disjointed health system, data stored in or generated by these different systems. They rarely cross their boundaries. So you see data all over the place. But to fix this, in New South Wales, we are implementing something called the Single Digital Patient Record, which the hope is that it will help bring together a lot of electronic medical records, systems, and patient administration systems, laboratory information systems. So all of those will be integrated in the next, and it's a project that will be done across, I think, 7 years or so, starting next year. And this just goes to show the scale of what we want to do. We want to integrate electronic medical records and all these systems across 228 hospitals for over about 8 million people. And you'd see that it's a mammoth, it's going to be a mammoth effort to bring it all together. But that's the plan for what we're doing in New South Wales. But this is the current situation. This is the current status. Your information doesn't really follow you as a patient. So if you go from one hospital to the other, your data doesn't travel with you. You'd have to state your case all over again, tell your history all over again, collect all the data all over again, and all of that. So these are the settings where I've conducted my research so far. So when you see me talking about, well, interoperability over and over again, it's because of the system we're in. Okay, so I will talk about the first program of work now, where we conducted this study in Australia's first virtual hospital, and we started the study in 2021, just around the time we were in lockdown or finishing lockdown. So it was around the pandemic as well, where the virtual hospital actually got stood up in 2020. So it was still all new, was very new for us. And so we went in there to identify barriers to detecting clinical deterioration and to sort of co-design solutions to address those barriers. So this was a large program of work. Grateful to all my co-authors and collaborators and the funders as well. Okay, I'm sure you do know this better than I do. Clinical deterioration, it occurs when a patient's condition worsens. It can develop at any time. But I suppose the most important thing I want to talk about here is the importance of time. Um, it's important for clinicians to be able to accurately and quickly detect and manage any form of deterioration, which is where we think clinical decision support systems could help. We think it could help facilitate timely detection of clinical deterioration and early management. But then I'm sure you do know that the implementation of this kind of systems is often hampered by poor workflow integration, poor user acceptance, and poor uptake. There was actually a meta-analysis that was conducted a few years ago that actually found that only about a third of clinical decision support systems are used by clinicians in practice. Only a third. Okay. So this study, we wanted to first understand the process. So what was the process of detecting and managing deterioration in a virtual hospital setting? Because it was all new for us. We were like, what the hell is going on, you know? And then we wanted to assess the work system barriers and facilitators and work out whether there were changes needed to the technologies in use. So we used a human factors approach. We used the systems engineering initiative for patient safety model, where we looked at elements of the work system, and we focused on the process of detecting deterioration and the process of managing deterioration. So we focused on two processes and then looked at the outcomes there. So this was primarily a qualitative study. We did interviews, we did document reviews, and we worked essentially with clinicians. We wanted to see what was going on in practice, and we did a thematic analysis and mapped our themes to the SIPS model. Following that, we created process maps. I'll only show you one of them today, the process map for detecting deterioration. Okay, so I know that's really tiny, you can't see, but I'll give you access to the paper. But essentially, we sort of mapped the entire landscape. So looking at all the stakeholders involved in detecting deterioration, and yes, patients were included. And we also looked at all the technologies and tools they actually use to facilitate that. And through this process, we were able to see what was happening and exactly where the bottlenecks were, the barriers. So where were the barriers occurring? What tools were they using at that point in time? Who was using it? And all the other factors associated. So this was really a worthwhile process for us. Yeah, and then we sort of wanted to see where the barriers sat, and you'd see that most of the barriers were within the tools and the technology domain of the SIPS model. And that was interesting. I'll talk a little bit more about that. So we found a number of barriers around the display itself, around workflow misalignment, decision support needs, and a lot of other areas like that. And I'll step you through a few of the examples to make it clearer. Okay, so for example, display concerns with the dashboard. So when a clinician in the virtual hospital setting, so this is how it works. Within the hospital, let's say a new patient is, onboarded, they would give some form of education, provide the resources, provide the wearables, all the pulse oximeters, everything they need, the entire kit, provide it to them, train them on how to use it, and off they go. So they go home, they get distracted, not distracted, they get moved into the virtual hospital, perhaps from the ED or from the wards. So once they move into the virtual hospital system, there are multiple systems. There's the electronic medical record, but then there is this dashboard that sort of helps them monitor the patients. So to monitor a patient and to look at the patient, remember the patient is at home. The patient is collecting all the vital signs data, the temperature, the blood oxygen saturation, all of that is being collected by the patient. And all of that data goes into an app. So the patient has an app, and the data from the app gets synced into the dashboard in some instances, in some cases. So for some patient cohorts, they get the data synced into the dashboard and the clinician can see it. But for some other patient cohorts, the clinician actually has to ring them up and tell them to say out the numbers, and they would manually record the numbers, okay? So, and the manual recording of vital signs happened for the majority of the patients. Anyway, so back to this point. Now, if a nurse wants to review a patient history before they make that call or before they assess that patient, they have to review that patient history in the electronic medical record. They also have to identify the model of care associated with the patient, and that information does not sit in the EMR, it sits in that separate dashboard. So two separate systems. And they also need to review the ISBA notes on the dashboard and in the EMR. They also need to review the most recent observation data, which syncs to the dashboard if that functionality is allowed, okay? So they need to review information in different places anyway. Now, within the dashboard, there is an observation pane that allows clinicians to see the temperature, the heart rate, respiratory rate, and all those vital signs. So you can actually see it there, and you can see, whether they're trending upwards or downwards and things like that. This nurse was reporting that it was really unclear what was the most recent observation data. So this person said it's very difficult to tell when each of those individual observations were taken. So it gives you a time, but it gives lots of observations, and not all of those observations may have been taken at that time. So imagine you see 8 a.m., but then the temperature was actually taken at 6 a.m., not 8 a.m. So you'd see lots of observations, but you cannot tell the age of that data. So that was a bit of an issue that we identified for the dashboard at that point. Another one was the layout concerns. Again, when reviewing patient history, this nurse unit manager was saying that regarding the dashboard, the layout was really confusing, the layout of the observation section. The observation section is where you've got your temperature, heart rate, respiratory rate, and all of that, all the vital signs. And this person said, well, we've been taught from the get-go that ABCs are the priority. Why isn't ABC a priority in the observations on the dashboard? I feel like a non-clinician designed it that way. Yeah, I found that really funny as well when the participant said that. So that was interesting. Again, a doctor talked about the layout at home, if working from home, and that happened a lot because remember it's a virtual hospital. They don't have to be in the hospital; they can work from home. But then the view at home, it sort of cuts off half your screen. Doesn't really work. In terms of the content issues, again, when reviewing patient history, this nurse was saying there's too much free text in a small box. And they're saying that the small box is like a little tiny 2 centimeter by 1 centimeter box where they actually have to write all these notes in there, making it really difficult to do and to track things. Then another task is deciding on the patient's risk level. So apart from assessing the patient, looking at all the observations, looking at all of that, the nurse needs to determine whether or not the patient has breached a threshold or is outside the range they would like to see. And there are many ways they do that. For some patient cohorts, they need to look into the electronic medical record, collect all the data, type it into the system if it's not transferred automatically. And usually for most of the patient cohorts, it's manual. So they need to type it in. When typing it in, there is an early warning score that can fire up if that patient is outside the range. Okay, so when you're in the system, that can fire up. That system is called the between the flag system. So that's the one that fires up. It's embedded in the EMR, but it's also different. But this person is saying that within that between the flag system, there's too much information for them. So they're saying that it's just that where there is oxygen delivery and there's a lot of information on that oxygen delivery and there are different methods of administering oxygen, that is a lot of information for me because all of that comes up on the screen as well. Now, in terms of workflow misalignment, again, I think this wouldn't come as a surprise to you. When manually recording vital signs and symptoms data, they need to record that in the electronic medical record. They need to record the same data in the dashboard, in the notes section of the dashboard. They need to record the same data in an Excel sheet on Microsoft Teams if that patient was sent to the hospital. They also need to record the same data in an email format and send it to their nurse unit manager if the patient's case is concerning, right? So they're, essentially typing the same thing over and over again in 4 different places. Duplication of work, inefficiencies, a lot of issues there. And so this person was saying it's not centered in one place, and that's why we are having to transcribe all of this observation data into another system, which is really inefficient. So I talked a little bit about this earlier, but I would explain it a bit better. One of the tasks here under decision support needs, one of the tasks they need to do is to continue to monitor the patient. So if the patient doesn't breach any threshold and there are no concerns, what they have to do is to continue to monitor the patient as per protocol, right? But then some participants noted that, well, there is no alert to notify a clinician of a deteriorating patient. So this participant was saying there's no pop-up or anything. So if you're not consciously looking at the results on screen, you may not notice. So currently, it could be very easily kind of missed. Remember I said earlier on that for some patients, once they collect all their data, their vital signs data, it goes straight into the app and the app syncs with the dashboard. For those patients, when the data syncs into the dashboard, the clinician will not know that data has come through, particularly if that data is trending downwards. So if that patient is outside the range and that data goes through to the dashboard, the clinician will not get any alert, will not know. So nothing to notify the clinician of a deteriorating patient. So that's in the dashboard. Now, in the between the flag system, which sits in the electronic medical record, another concern was that the alert that fires in there is reactive, and it cannot notify a clinician of an impending deterioration when the patient collects vital signs at home, unless you as the clinician remember to prompt for this. Okay, so this person was saying that between the flags is developed for a face-to-face situation, whereas what with us as the clinicians not being with the patients and them doing their vital signs at home, if they're not sure, they rely on us to go there and check what they are. So at the moment, if the clinician doesn't go into that patient's file and open that record, this between the flags alert will not fire up if that patient is outside the range, because that's how it works in a face-to-face setting. But for a virtual setting, they're like, this doesn't work, this isn't safe, because you cannot continue to eyeball the screen and pick on every patient to double check what's going on with them. So anyway, this was picked up and we decided to do something about it. So what did we do next? Because of time, I only went through the technology barriers. There were a lot of other barriers and facilitators in all the other domains of SAPES. So I'll just talk you through what we did next about that. So the barriers gave us the opportunity to tackle this problem with the health service. So we ran focus groups after the work system analysis. We wanted to better understand the clinical documentation challenges, because you could see there was a lot of duplication of work, typing in things in multiple places and all of that. So we wanted to unpack that, and that was really interesting. We ran focus groups with doctors separately and with nurses separately, and it was like, oh, this is really scary. what they were going through. And then we did workshops. So we did workshops to tackle specific problems that the health service was particularly interested in. And one of those was the issue of the decision support tool. They thought it was really important to sort of work out how do we get a decision support tool to help manage or to help support the detection of clinical deterioration. So we did a co-design workshop on that. We also we did another workshop, a couple more workshops on clinical documentation and customization of the existing dashboard. So I'll talk about the one in bold next. So we had 14 stakeholders. We had nurses and nursing managers, doctors, IT staff, and even the vendors were there. And so we asked them 4 questions essentially. What type of decision support do you need? Which one is most appropriate and why? Okay. When should the CDS be delivered in the workflow? This was really important for us because we did not want to, add things on top of all the system they were already using. What information should the CDS contain? What should it look like, and all of that. And so we picked one question, had a group discussion, shared feedback, and went in circles like that until we went through all the 4 questions. I just thought I might show you what the dashboard looked like initially. It has changed by now. This is what it looked like initially. And you'd see just on the right-hand side, this is the observation pane I was talking about. You see your pulse, temperature, heart rate, things like that. All of that, they are on the left. The patient identifiers are here, and some other details in the middle. So that was what it was initially. And so for the new decision support we wanted to co-design, we wanted it to be an additional functionality on top of this one, on top of this dashboard. So that was the goal. And so at the end of the workshop, people thought, okay, let's go for a passive CDS rather than an interruptive one, because you could have 200 patients. You don't want all the alerts firing at the same time. So we decided to, based on the workshop, we decided to be really clever with how information was displayed and with the interface design to try and target those issues we found. And there were 5 main things they wanted, okay? They wanted us to incorporate data from virtual assessments, which is interesting because not many clinical decision support algorithms incorporate clinician concern. They said it was important for us to incorporate clinician concern because based on how you see them on a video call or what you hear from them, you could tell whether you're worried or not, what your gut feeling saying about this patient. And they thought it was important to incorporate that data into the CDS algorithm, which is interesting. Another one was highlighting patients at risk of deterioration. So looking at this view, for each row belongs to a patient. So actually highlighting each row depending on where they sit. So if a patient is at risk, highlight them based on the vital signs data, whether it's trending, in the wrong direction or not, the patient reported outcome measures data, what their survey says about how they're feeling, and clinician concern. They thought based on those that we should highlight patients that are at risk. Then they also thought that it was important to emphasize visibility of critical data. For example, rather than just highlighting, that we could actually use color codes like a traffic light system. People who are training, who are really outside the range, in the yellow range or in the red range, use color codes to identify that and also reorder the patient list. So people who are in the red zone, for instance, bring them to the top of the list, highlight them, people in the yellow zone in the middle, and people who are okay at the bottom. They mentioned that. They also mentioned providing easy access to key information. It almost sounds like a no-brainer, but they specifically said it would be important to highlight, to use flags to indicate why a patient is at risk. Why have you highlighted that patient? Use a flag to explain that and also create timestamps as well, because they would like to know how long that patient has been in that state. how long the patient has had the at-risk status. And the final one is to support de-escalation with caution. They would like us to retain that at-risk status until a clinician reviews that patient, and then the clinician can manually de-escalate with care. So that was how that went. And the health service has been working with the vendor to actually develop that functionality based on the findings. And they're also working together with partners to improve all the tools and technologies used for detecting deterioration. They already made a lot of changes based on this study, and they're still making changes as well. And the health service is also tackling all the other challenges in the other domains of the SIPS model. And here are links to papers if you want to have a read. The one at the top left is the work system analysis we did. The one at the bottom left was a qualitative piece we did trying to understand the impact of the pandemic on clinician IT dynamics within the virtual hospital, which was also a very interesting study. And the third one on the right as well. 2 more papers to come. Good luck to me writing. Okay, so that was the first study. The second one is in a different setting, also virtual care as well. This was around optimizing virtual care delivery between general practice and residential aged care homes. And I'll tell you the reason for that pause in a second. Okay, so first off, I'd like to thank my co-authors and funders again for this study. This was a large study, but more recent than the other because we actually did this study last year, stroke this year. Again, virtual care, as you know, can support better access to GP services for residents in aged care homes. I don't know if you use facilities here or homes. We use homes in Australia. And we hope it could, reduce presentations to the ED and hospital admissions. But again, as you know, technology implementation is tricky, and this may impact adoption as well. But we were very opportunistic with this study because around the time we're crafting the proposal for this work was the time when the Sydney Northern Health Network wanted to implement virtual care, a suite of virtual care technologies in their network. And we're talking, the network is as large as over 288 general practices, so very large. And so they wanted to implement the system. It's got quite a lot of functionalities. That 6-in-1 remote monitoring device that uses Bluetooth technology to connect to digital stethoscopes, otoscope, and all these other fancy gadgets. It's got a dashboard as well. And here is a summary of, the virtual care platform. It was, really fancy, and we're like, yay, this is great. Let's evaluate this. Let's see how well it works in practice. Again, thinking about virtual care technology implementation and adoption, oftentimes when I talk to people, the usual thing people say, or the first thing people say to me is training. Okay, train them, just do staff training and all will be well. And I was like, well, all will not be well in this particular setting because it's a unique setting on its own. There's high workload, there's high staff turnover, there's low digital literacy. If you train a cohort in January, by April, they are gone and you have to start all over again. So how can you rely on ongoing staff training? And then I said, well, are they easy to learn? This system should be easy to use and easy to learn so that they can be intuitive enough for anyone to pick it up at any time. So we went in there with that thought and said, okay, how about we evaluate the learnability of these technologies and also work out the barriers and the facilitators of implementing these technologies in practice. And that was what we did. Again, we used the SIPS model to guide that work. And we did 2 things. So we did what we call a cognitive walkthrough analysis, and we also ran semi-structured interviews. So we spoke to everyone involved, general practitioners, practice managers, the nurses in the aged care homes, residents and carers and everyone. And we did a thematic analysis and mapped our themes to the SIPS model. But I will talk about the cognitive walkthrough analysis first. It's a method, it's a usability inspection method. I don't know if you're aware of it, but it essentially helps us assess how easy it is to learn an interface. So we wanted to assess that. So essentially, a human factors expert will walk through each of these steps involved, each of the user actions involved in a step, and then would sort of evaluate against a set criteria. So there were 4 questions we were going off by, where we wanted to check whether users would understand that an action is needed to reach the goal, whether users will notice that the correct action is available. And so we actually systematically walked through each of these questions for each task on the interface, which was a mammoth effort. So it involved 2 human factors experts. We had a GP, we had a nurse, we had an active resident, and we did have this session at our own simulation laboratory. I'm glad I've got a photo to show you there. And following that, we had 2 2-hour workshops to actually determine the severity of these problems. So we did a GP workflow workshop. So we did that together with a GP, and we had a GP actually telling us how severe they thought that problem was. And the same for the nursing workflow. We had a nurse telling us how severe they thought each problem was, and we did all of that. And so the scores from 0 to 4, 0 meaning cosmetic problem, 4 meaning catastrophic problem. So we identified 48 usability problems. Half of them were on learnability. So the system wasn't very easy to learn. And so we broke down our results into 3 categories, and I'll talk you through that now. So the first category is based on the cognitive walkthrough questions. So those 4 questions, of the 4 questions, the first one was the one that had about 9, the highest number of learnability problems, because users did not know what to do to accomplish certain goals. And I'll give you an example. For example, it wasn't clear that a user needs to click on disconnect to connect the remote monitoring technologies. So counterintuitive, right? So you actually need to click on disconnect to connect. And then it wasn't also clear that the user needed to click on a serial number of the device found by Bluetooth to actually connect to it. So there were a lot of steps in there. There were quite a few things that you needed to be really comfortable doing. For those interested in the numbers, for those who love numbers, I put this up there, showing the spread of the issues we found. You'd see that there were not many issues within the GP workflow, but the task that had the biggest issue was viewing current and previous vital signs for a resident. That was a bit tricky for GPs. And within the nursing workflow, capturing a resident's vitals was particularly challenging. It had 14 learnability problems there. And also joining a resident to a telehealth call, if you look at the highlighted part, we found 1 catastrophic problem, which I'll tell you in a sec. So for the GP workflow, the GP task, viewing current and previous vital signs was a problem, because the overview page on the dashboard, the overview page for the GP actually only showed the last data point. So you cannot see multiple data points, even if that data is collected on the same day, which was really annoying for our GP. Then for the nursing workflow, capturing resident vitals, which I would say was like the most important task they needed to do, it was really problematic. Also joining a resident to a call. So in the way it's meant to work in the aged care home is there is a stand and there are 2 iPads, 1 iPad facing the nurse and the other iPad facing the resident. And so you as a nurse, you're meant to connect yourself first and then connect the resident, because the resident iPad is facing the resident on the bed or on the chair or whatever. But to actually join that resident to a call was really challenging. And while we're trying to make that work, we're toggling with different things, and we click the back button. Unknown to us, actually, the back button ended the call from our end, but then the GP was still in the call. So the GP was sitting there waiting for us. Where are these people? What's going on? The GP is still there. We're waiting, but we did not know. So that was, and when we're chatting with the GP and the nurse after the session, they were like, well, That's a no-no, because I would think the GP was like, I would think they just left me hanging, and they're just wasting my time and all of that, not knowing it's the fault of the technology. We found many other issues. I'll talk a little bit just on error. This was a big one because the way the dashboard is designed, you can see the patient in the middle, a big screen in the middle, but below that, there are some tabs where you can look at overview, look at vital signs, and you can also write your progress notes. But the problem is when you're typing your progress notes, if you move across tabs within that same view, you'd lose all your data. Okay, so the progress notes are not saved automatically if you move across tabs. And that was identified as a big issue because no one wants to do their progress notes twice. Yeah, and a few other issues as well. I'll just move on in the interest of time. And for the interviews, we interviewed 33 people, and then we categorized our themes on barriers and facilitators and mapped them to the SIPS domain as well. Okay, so people, this came across a lot. Communication barrier came across a lot. A lot of people complained about, hearing impairment, visual impairment, language barriers. So this nurse was saying, sometimes the language barrier can still be quite relevant for the older person if they've got a hearing loss or cognitive decline. So sometimes things get lost in translation. Again, the GP also echoed that, saying that the inability to hear and to see properly, results in communication difficulties. So that came across quite a lot in terms of virtual care calls with and without video between a nurse in an aged care home and a general practitioner in their practice. Tools and technology, no surprises here. Lack of system integration came up again. Poor network connectivity, that was surprising for me because I thought, come on, it's Australia. Surely our internet must be good, but no, not really. So this participant was saying you're always constrained by things like reception and really good network coverage in residential aged care. There's always a black spot. So yeah, so that happened. Again, poor learnability came out in the interviews as well, which sort of aligned with what we found earlier on. This GP was echoing that as well. Okay, the setting itself, high staff turnover came up, logistical challenges of actually making the virtual care consult work, that actually came up as well. So if you look at the bottom quote there, it says it can be quite difficult to get the nursing staff in with that patient at that time. Because when you call the GP and say, well, we need you to have a look at this patient, the GP would say, oftentimes say, well, I'm with another patient right now. How about I ring you in half an hour? And then when the GP rings in half an hour, they would ring the aged care home, and it's the manager that would likely pick the call and go, who did you speak to? Which nurse? Which patient? And so they need to go hunt for the nurse, and the nurse will go hunt for the patient. And by the time all of that is done, the 15-minute slot the GP actually had for that patient is gone. And so they have to start all over again. So major logistical challenges. And then unavailability of dedicated smart devices as well. That came up as well. The task focus barriers, documentation burden, I think no surprises here as well. And it was reportedly due to policy because they needed to collect quite a lot of data, document everything. But because they were doing it multiple times in multiple systems, and because these systems don't talk to each other, it sort of led to inefficiencies. Okay. So this person was saying when you've got to repeat what you've done potentially 3 or 4 times, whether it's a PDF document or you cut and paste, it's a real issue. And the general practitioner there was saying that's a big pain point for a lot of clinicians. It takes some time to upload their notes. Sometimes they might have to email them. So yeah, that came across as well. Then environmental barriers, internally, noise was reported. So some were saying, well, the voice is not clear due to background noise, and then privacy. So we had a resident saying that, well, even when we're in the room, there will be other people in there. For example, even if it's a shared room, they tend to do these virtual care calls in the room of the residents. But if it's a shared room or if there are other people there, privacy isn't necessarily guaranteed. Then the funding model as well, a lot of GPs complained about there was a new incentive payment that is meant to actually encourage GPs to go into aged care homes and to do virtual care with aged care homes. But the way it's all set up, it makes it even twice as hard to actually do that. So it was counterproductive at the end of the day. Facilitators, quite a lot of people actually praised nurses, particularly because they helped make the virtual care calls work if they are there. If there are no nurses there, it just doesn't work because, would you give the instructions to what do they do and how do they do it and all of that. So that came up. Also, familiarity was important. Participants noted that when the resident was already familiar with that GP and has a relationship built over time, knows the GP, trusts the GP, even if it's on screen, they could still relate to the GP rather than someone that is totally new to them. Then tools and technology, we actually found a lot of people turning to third-party software, FaceTime, WhatsApp. People were doing that. We're like, hang on, why are you not using the enterprise licensed products like Teams and Zoom? And they're like, well, no one wants to fiddle with links, to actually get all of this work. It's really tricky and challenging for them. So people would just go, I'm using FaceTime or I'm using WhatsApp and just get a call done. So that came up and it facilitated virtual care, I will have to say. A lot of people also noted that the fact that they could remotely gain access to the clinical information systems in the aged care homes, that also helped a lot because they could see the patient data. Training was a bit of a mixed bag. People thought it was good that some of their staff were trained, but people thought that the training could be more realistic for them. Maybe somewhere to add in the virtual reality training that you showed me earlier. Then in terms of tasks, collection of vital signs, the fact that there's actually all these new fancy gadgets that you can use to collect vital signs and symptoms and share that data in real time with the GP, people thought that was a big plus, so that was good. Policies and procedures, a bit of a mixed bag because they thought, well, the government and everyone is recognizing that virtual care is here to stay and people are trying to enable that. But the problem is legislation often goes or follows after technology. It doesn't go at the same pace that technology is going. And so we're having to retrofit our policies to match the technology over time, which needs work, I would say. So we're using our findings to optimize these virtual care technologies, and we hope that our findings will also provide guidance to policymakers to help improve virtual care delivery in New South Wales. So we are putting together 2 papers from this work, one on the review, one in writing. And yeah, I'm doing good with time. Take home message. So I think that there are 5 reflections I've got. One, a bit of a sell of human factors. Please engage us early on. It's valuable to engage human factors expertise early on before it's too late, before you have to actually spend more time, spend more money to fix things. Also in our research, we highlighted, we're able to identify multiple opportunities where clinical deterioration processes in virtual care could be optimized. Through our learnability study, we found that design that actually prevented users from being aware that they needed to do something was most identified. And that was something that we tried to highlight in our paper that, for whoever is developing virtual care technologies. Then capturing vital signs with the virtual care platform was really hard for nurses in aged care homes. And I'm hoping that, when designing virtual care technologies, people can start to think about how it's being used in practice and to sort of mitigate all those issues and reduce the number of steps people need to carry out to be able to do these tasks that they will have to do frequently on a daily basis per patient. And the final point there is my plea to system designers to try and ensure that these technologies are indeed functional and that they have meaningful cues and fewer actions from users so that we can collectively improve user experience and prevent unintended consequences. So that's it from me. Thank you so much for sticking around, for listening.